Hello, all doctors planning for MRSOG Part 1 and Part 2 exam. Today we will discuss a summary about one of the newest doc articles which is published in year 2023. It's talking about tuberculosis in pregnancy. Although the prevalence of TB is not big in UK, but it's still one of the important topics because to many doctors, maybe it's not clear how we can diagnose, how we can prevent, how we can treat tuberculosis in pregnancy. So in year 2020, there were about 4,700 cases of TB in UK. Overall, the world, there are some specific areas in the world which have high prevalence of tuberculosis, mainly in Southeast Asia, followed by Africa. If we talk about Southeast Asian countries, this is including India, China, Indonesia, Philippines, and Pakistan, and some other African countries. These countries together are responsible for 2/3 of the cases of tuberculosis in the world. If a person coming to an UK as an immigrant, he has risk of catching tuberculosis, especially in the first 5 years of coming to UK, because in these 5 years, usually there will be contact with new persons. So this increases the risk of exposure. How tuberculosis can be transmitted? The most common form is airborne infection. That's why the most common site of TB is pulmonary TB. Also, it can affect the abdomen and the intestine, GIT, because it can be transmitted by ingestion of unpasteurized milk. Also, it can be transmitted by contact, although this is not a common source, but it can happen if there is abrasion in the skin or conjunctiva. This bacteria can be transmitted. Also, perinatal, so it can be transmitted either from the mother to the baby transplacental or even to the newborn if there is one of the people attending is infected with coughing or sneezing, he can transmit the infection to the newborn. If the infection occurred transplacental, what do you think? What will be the first organ to be affected? If we imagine the blood will pass to the baby through the umbilical vessels, it will affect the liver. So liver is the first site in the baby to be affected. So in adults, lung is the most important, while in the fetus or in the newborn, the most important is liver to be affected. Okay, 10% of healthy adults will acquire infection during their life. Infection will be at first latent phase, then can have pulmonary phase, which is active phase, then secondary TB. The problem is more serious if the person is immunocompromised. 10% if immunocompromised individual with latent TB will have reactivation. That's why HIV is a very important risk for reactivation because the person will be immunocompromised. So we have latent TB, asymptomatic, then the primary, usually the lung in adults, about 80% the lung will be the organ in the adult to be affected. The appearance in X-ray appear in the form of lung lesion and hilar lymph nodes involvement. So there is positive hilar or peritracheal lymph nodes. This is called Jones focus. So Jones focus is an area in the lung affected by TB and there is hilar lymph node enlargement and involvement. So pulmonary is the most common 80%. The remaining 20%, the most common site in the remaining 20% in UK is cervical lymph nodes. It can be as an exam question. What is the most common form of tuberculosis in adults? The answer, pulmonary, 80%. What is the second most common site of TB in UK? The answer in cervical lymph nodes. Another question, what is the most common form of TB in the baby intrauterine? The answer, liver is the most common organ to be affected. So what are the clinical picture of TB? You will find there are general symptoms like fever, fatigue, night sweating, loss of appetite. Manifestations specific to the organ involved like lung, cough, hemoptysis, dyspnea. And the chronic cough more than 3 weeks is always alarming that there is abnormal problem. We need to do X-ray, we need to investigate. Latent phase, usually asymptomatic. Okay, the most severe and lethal forms are miliary TB, disseminated TB, and meningeal TB. That's why always CNS involvement is very risky. So it will have specific additional steps in the management, like adding corticosteroids to reduce the inflammation in the brain tissue. WHO said if any person has fever, night sweating, cough, and weight loss, please screen this person for TB. Although the patient, as you see, doesn't have pulmonary symptoms. That's why in the investigation, we need to differentiate, are there pulmonary symptoms? So I will concentrate more upon chest X-ray and testing the sputum, like doing microscopy or culture. Or if the patient doesn't have pulmonary symptoms but suspected to have TB, then we can screen by doing some serology testing or searching for, as we will see about what's called IGRA. Okay, TB can affect multiple organs: the abdomen, CNS, skin, genitourinary, lymph nodes, musculoskeletal, ocular. You will find inflammation in any organ which is affected, and every organ of these can have its specific suitable lines of investigations. For example, for the abdomen, we can do ultrasound, we can do CT, endoscopy. For meningeal, we can do CSF puncture, we can do CT, we can do MRI, something very logic. Okay, for the pelvis, imaging, taking biopsies. Okay, and lymph node, also we can take fine needle from the lymph node. If the bone is affected, we can take X-ray images or CT or MRI. So according to every organ affected, there will be specific manifestations caused by inflammation of this organ. And also you will find there is suitable, something very logic, no need to be memorized by heart, imaging and investigations for this organ. Okay, so if we need to talk generally about the investigations for TB, this will include screening test, confirmatory test, and imaging. Screening, the most important is tuberculin skin test. Another test, interferon gamma release assay. Interferon is one of the cytokines. We measure its amount. In tuberculin skin test, the principle here that we inject a material called purified protein derivative intradermal, and if the patient has TB, the immune system already identified this antigen before and will induce excessive induration. So I am searching for this excessive induration as an evidence. Also, if interferon gamma release assay is high, so this is evidence that this patient can have TB. Confirmatory test, microscopy. You can take sample, like sample from the sputum, from affected lymph node, from cutaneous tissue, from intestinal lesion, from CSF, anything. You can do microscopic examination. And as we know, the stain that we can use for identifying Mycobacterium is Zell-Nielsen stain. Zell-Nielsen stain. We know it appears like acid-fast bacilli. Also, we can do culture and sensitivity. We can take specimen from any involved organ, and we can use specific cultures like Liechtenstein-Jensen media. The problem with Liechtenstein-Jensen media, it can take longer time to give you a result. Then you will do sensitivity test. It will take additional weeks. This is long time. That's why there are new recent methods that we can do rapid culture which can give rapid results. And we have imaging. The most important will be X-ray chest, of course, because X-ray chest can show Jones lesion as we saw, which is a lesion in the lung and positive lymph nodes. Okay, which of which? It depends. Your patient is symptomatic or not. If symptomatic, mainly talking about lung problems. Or I am doing screening because there is fatigue, loss of weight, anorexia, and so on, night sweating. So if the patient is symptomatic, so there are mainly pulmonary lesion, so there is cough, dyspnea, and so on. I can do chest x-ray, sputum samples. I need 3 samples to say it's negative. Microscopy and the culture. Microscopy, you can stain with Zell-Nielsen stain, and you can use culture on Liechtenstein Jensen media or the recent types which can give fast result. And culture sensitivity. If the patient doesn't have pulmonary symptoms, I am just trying to do screening, or the patient has non-specific symptoms. So don't think of sputum or lung, think of serology, like IGRA or tuberculin test. Tuberculin test, as we said, will inject purified protein derivative and you will see the response. If there is specific response, so this can be TB. IGRA is testing the amount of this cytokine, which is IGRA in the body. So if any one of them positive, so there can be TB. Now I go to do imaging to the lung or take sputum samples. But if IGRA or tuberculin test are negative, if they are positive, but I don't suspect that there is TB, okay, this can be latent TB. Latent, so the patient is asymptomatic. Okay, so again, how we can do tuberculin skin test? We inject this material intradermal. It's called purified protein derivative. Don't worry, this material does not lead to actual infection. So this test can be done in pregnancy. And the interpretation in pregnancy, same like non-pregnant, there is no change. There are 2 methods that we can use tuberculin test. A method called Tyne, another one called the Mantox, and the Mantox is the most commonly used one. Okay, I injected this purified protein derivative, and after 2 to 3 days, I will check the response. I am expecting, if the patient has tuberculosis, that I will find area of induration, its diameter 5 to 15 millimeter. If this happened, mostly this is TB. If this didn't happen, mostly this is not tuberculosis. Are you sure? No, because there is false positive and false negative. False positive, so induration happened, but there is no TB. False negative, that the patient has TB, but I didn't get this 5 to 15 millimeter area of induration. You can be asked in the exam, which of the following is a reason for false positive or a reason for false negative tuberculin test? False positive, if the immunity is stimulated because the patient is vaccinated, or the patient had old infection, not current infection, or the patient was infected before by Mycobacterium but not Mycobacterium TB. It can be Mycobacterium bovis, for example, not a must to be tuberculosis itself. False negative, why the induration didn't happen? Technical issue, wrong injection, insufficient injection, the material is not valid. Recent TB, very recent, still the immunity is not ready to give you the specific reaction. Or the patient has severe immunocompromised state, like non-Hodgkin lymphoma, sarcoidosis, immunocompromised like HIV patient. Don't expect to have the usual immune response in these patients. Also, if the patient had recent live vaccination like measles or chickenpox, the immune system is concentrating more with these vaccines, not concentrating well with giving you the expected reaction in tuberculin test. The materials that can be used for tuberculin test. The old one is purified protein derivative. Now there is a problem that this material is not widely available. There is excessive shortage of the availability. So a new material called CTP, this is the one that is used nowadays. It has another benefit, less false positive. So the more available now, not BBD material, the most available one, CTP. It has another advantage, less false positive results. Another one of the screening test is interferon gamma release assay. The principle of this test that we inject tuberculosis specific antigen. Then we see the immune response and we count how many cytokines, the amount of cytokine interferon gamma is released. Okay, so this is another one, interferon gamma release. We call it EGRA test. Another test is microscopy, that we take sample of the sputum or sample from lymph node or sample from caseation of the inflamed tissue and we stain it with Zell-Nielsen stain. This is a stain that is used so we can detect tuberculosis bacilli, mycobacterium. Or we can take this specimen and we can use culture on Liechtenstein-Jensen media. The problem, it will take weeks to give a response and additional 4 to 8 weeks so we can do antibiotic sensitivity test. So talking about total 8 to 16 weeks, which is long time. That's why there are new automated systems. It will be better than using a culture. So it will give response within 4 to 14 days. There is a more recent one using PCR. It can give result within 2 hours. You can give response and also you can identify the sensitivity and resistance to the antibiotics. So we talked about tuberculin test and we talked about EGRA test. Also we talked about using microscopy with Zell-Nielsen stain and using a culture on Liechtenstein-Jensen media or the new automated media or using even PCR which can give response within a couple of hours. Imaging, mainly our target will be chest X-ray. In the active case, you will find the lesion and the hilar lymph node which call together Jones focus present mainly in the upper zone. But in treated cases, you can find lesions in the middle and the lower zones. So in active pulmonary TB, in the upper zone of lung. In treated, you will find lesions in the middle and in the lower parts of the lung. Okay, so now as one of the infections, how it can affect the pregnancy? Normally, the pregnancy itself is immunocompromised state. Why? Natural killer cell activity is suppressed. The interleukin 10 suppressed, and even T helper inflammatory response is down-regulated. So pregnancy generally is immunocompromised state. That's why the complications will be maternal and fetal. The baby itself, the bacilli can pass transplacental to affect mainly the liver, as we said. So the effect of the pregnancy will be coming from the bad general condition of the mother herself and the transplacental infection, which is called perinatal TB. So prematurity increased, small for gestational age, oligohydramnios, so placental function is compromised. Even maternal death, 4% of mothers with TB, they died. If the TB is extrapulmonary, like hepatic, lymph node, and others, additional side effects: anemia, oligohydramnios, hypertension, gestational diabetes, BPROM, obstetric cholestasis, small for gestational age, and poor Apgar score, neonatal respiratory distress syndrome. HIV is an independent risk factor for fulmination and reactivation. It increases the risk of reactivation 20-fold. That's why it's a very important risk factor. So now we talked about the clinical picture, how to do screening, how to diagnose using screening test, confirmatory test, and imaging. And now we talk about the treatment of tuberculosis itself, how we can treat and what are the regimens of treatments and these medications are safe or not with pregnancy. Of course, with a serious infection like TB, the benefit will be much more than the risks of about all the antituberculous medications, except streptomycin, which is not used in pregnancy. So all other antituberculous medications are safe except streptomycin. And the early treatment is an important key for success and reducing the risk of complications. So treatment start as early as possible to reduce the risk of maternal and fetal complications. How we can treat active TB? We give 2 months INH, rifampicin, pyrazinamide, and ethambutol. So 2 months Harzi, Harzi. Then 4 months of HR, which is INH, isoniazide, and rifampicin. So 2 months Harzi, then 4 months HR. So HRZE, then HR. 2 months, then 4 months. Isoniazide, which is letter H in both of them, it has some serious side effects, including neurological manifestations. That's why pyridoxine is important to be given to protect against these neurological toxicity complications. Also, it has another effect, which is hepatotoxicity. So 2 months Harzi, then 4 months hard. Don't forget, whatever in the initiation phase of treatment or continuation phase, as long as both of them containing isoniazide, which is letter H, we have to give pyridoxine 10 mg per day. So here we find the summary about the medications. Harzi, H is isoniazide, R rifampicin, Z pyrazinamide, and E ethambutol. Here are the doses and the side effects. Isoniazide, don't forget nerve complications and hepatotoxicity. You will find in Z and E, both of them has side effects on the joints, gout, arthralgia. They are important. All of them are safe, can be used in pregnancy. There is one specific extra management. If this is CNS involvement, we need to reduce the inflammation in the brain tissue, so corticosteroids, whatever dexamethasone or prednisolone, need to be added to the treatment to reduce the nervous tissue inflammation. Okay, so this is something specific to CNS infection. Another thing specific to CNS infection, that the duration of treatment will be prolonged more if there is CNS infection. So if this is CNS infection, it will be 2 Harzi and 10 Har. So in non-CNS, 2 Harzi, 4 HR. In CNS, it's 2 Harzi, 10 HR, plus corticosteroids. Whatever you will give prednisolone or dexamethasone to reduce inflammation in the tissue, and whenever we are going to stop the steroid, it should be stopped gradual, and the baby, we may need to give stress dose of steroid in labor. So all antituberculous, safe. Category C, except streptomycin. We don't give it in pregnancy because risk of irreversible deafness. And with isoniazide, which is letter H, don't forget hepatotoxicity and nervous toxicity. Latent TB. The treatment will be less aggressive than active TB. So we can give either one medication, which is isoniazide, 6 months, or 2 medications for 3 months. So you can give it more condensed or you can give it over 6 months. So one medicine 6 months, which is isoniazide, or isoniazide and rifampicin for 3 months. So 1 in 6 or 2 in 3. Don't forget, with isoniazide, we need pyridoxine to reduce the neurological complications. Hepatotoxicity, you can be asked in the exam. With isoniazide, when hepatotoxicity can happen, it can occur in 3rd trimester or early after delivery. Perinatal, how the baby can be affected. The baby can be affected intrauterine, transplacental, or after delivery from one of the attendants, the most important organ to be affected in the liver. Unfortunately, the neonate is at risk of having miliary TB. This is the most common finding in chest X-ray. How we can diagnose it? After delivery, you can do testing to the placenta itself. You may find it has a tubercle bacilli. Diagnostic criteria suggested by Cantwell et al. For diagnosis of perinatal TB that you find the newborn in the first week of life has lesions of TB. Primary hepatic complex, we said in the baby intrauterine liver is the most affected one. Placental or maternal genital tract TB excluding likelihood of transmission by postnatal contact. So if the placenta is positive, so the infection coming through the placenta, not coming from one of the attendants after delivery. Perinatal TB is very serious, and unfortunately risk of neonatal mortality is high. So the risk of mortality with perinatal TB is very high. Even if the baby is treated, risk of mortality is 22%. If the baby is not treated, risk of mortality is very high, 38%. How we can treat? 2 Harzi and 4 RHE. 2 Harzi, same like the treatment in the adult, but 4 months here is different. 4 months of RHE. Don't forget, whenever you give H, which is isoniazide, we should give pyridoxine to prevent neurological complications. This can come as an exam question. Whenever we treat TB with isoniazide, which is letter H, which vitamin should be given? The answer, pyridoxine. Don't forget, in hyperemesis gravidarum, we give also one of vitamin B complex, but in hyperemesis it's thiamine vitamin B1, so notice the difference. What about breastfeeding? If we talk about the antituberculous medications itself, although they pass into the breast milk, but it's not a contraindication for breastfeeding, so their effect, no adverse effect on the baby. So the medication itself is not contraindication for lactation. So when contraindication of lactation will be present? If there is breast mammary TB or multi-drug resistant TB, so very virulent organism, or the patient has associated HIV. Here the infection can be very virulent. Here better to avoid breastfeeding. And at last, a small hint about BCG vaccine. BCG vaccine is routine for all newborns in countries with high prevalence of TB. But in a country with low prevalence TB like UK, the vaccination will be targeted for a specific group of newborns. So how this vaccine is prepared? It's live attenuated Mycobacterium bovis, not Mycobacterium TB. It's from Mycobacterium bovis. Mycobacterium bovis, its main pathology in the animals, and it's less weaker than Mycobacterium tuberculosis. That's why it's the one that is present in the vaccine. But because it's live attenuated, it's never given to a pregnant woman because it may induce actual infection during pregnancy. So, if high prevalence country, it's routine for all newborn, single dose after delivery. But in UK, we select. We have two indications. Either the father or mother or grandparent of the child are living in area with high prevalence, which is 40 in 100,000. Or the baby itself after delivery will live in an area with high prevalence of TB. So whatever, parents or grandparents or the baby itself will live in area with high prevalence, same number as you notice, 40 in 100,000. This is an indication to give the vaccine to the baby. The vaccine is never given to a pregnant woman because it's live attenuated. Also not given to the baby if the baby is immunocompromised because it may induce actual infection. Okay, if a person has a scar in the arm or in the area of the shoulder of previous vaccination, does this confirm that the vaccine was effective? No, it does not confirm 100%. The benefit of the vaccine: when it's given to the newborn, it will protect him as a child and also to some extent can protect him as an adult. So this was a summary about this interesting talk article about TB in pregnancy. Some questions that can be asked in the exam about what is the name of the bacteria? It's Mycobacterium TB. What stain can be used? It's Zell-Nielsen stain. What culture? Liechtenstein-Jensen, or better that we can use the recent ones because Liechtenstein-Jensen, when you use it for culture, then sensitivity can take up to 16 weeks. Better to use PCR, which can give result in 2 hours only. Okay, also what is the most common organ to be affected in adults? Lung. In the newborn, liver. So transplacental infection can occur. Vaccine never given to pregnant women, usually given to newborn, either in high-risk countries to all newborn, in low-risk countries like UK, only for selected newborns. So during the antenatal care, the midwife already will discuss with the woman if her baby will need or will not need BCG vaccine according to the parents or grandparents or where the baby will live after delivery. Don't forget the importance of pyridoxine for any patient with TB receiving isoniazid, which is letter H. Pyridoxine should be given to prevent neurological manifestations. So this is a summary about this interesting talk article. And with you, I am Osama. I am RCOG examiner and MRCOG course instructor. And thanks much for your attendance and your concentration. Thank you so much. Bye.